Welcome to Dental XP. I'm Dr. Maurice Salama, and today we're going to be speaking about management of the posterior maxilla and mandible, in this case a lower molar that's been previously extracted and grafted, and how today we have variations and versatility in armamentarium to manage these types of tooth replacement issues. This patient had bone grafting done approximately 3 months prior to returning to our office, and we were challenged with being able to replace this large molar area, and many different options are available. And today what we're going to do is make a small crestal incision, making sure that we split the remaining keratinized gingiva to have adequate amounts of gingiva on both sides, on the lingual and buccal aspects of this molar site. We use a back action chisel to gently reflect the buccal flap and to expose the underlying osseous form. We're able to evaluate the extent of the bone fill from the previous extraction. This was done utilizing mineralized irradiated bone. And some of the issues with molars has been recently the utilization of super wide molar implants for these areas, sometimes often to avoid sinus lifts in the maxilla and often to avoid the mandibular nerve in the posterior mandible. In addition, we sometimes just have the option of having a better utilization of the large ridge in the posterior region from a biomechanical standpoint, having a large molar restoration being supported by a larger diameter implant. Taking a look at this from the occlusal view, you can see very good bone fill, bleeding bone in this area. And we're going to utilize today the Megagen Rescue implant system. We're going to use a trephine, and what you're seeing here is a trephine that has a stop. So in areas where we want to avoid anatomical landmarks such as the sinus floor, nerve, this stop that you see in the middle is adapted to the trephine drill, which allows us to create the area for the placement of the implant without having to worry about harming these very important anatomic areas. We first place the drill on reverse in order to score the bone. Many times in dense cortical areas, the drill will bounce and shake if we have it going in a clockwise direction. So first counterclockwise with the drill, scoring the bone, and then coming back with clockwise direction. You can see that there's the laser markings that will allow for the depth. In this case, we're going to be placing the 8.5 millimeter depth of the implant. So we have the stop in the inside of the trephine that makes sure that we can't go beyond the depth that we want. And this is very important so we can be very sure and certain that we're not going to go beyond that depth. And you can see the stop engaging the crestal bone. And this inner core of this trephined piece can then be lifted. Here we're using very small chisels to pry out the inner core. Now this can be done at the time of extraction. Some people suggest with the septal bone, but it can also be done at approximately 3 months, like in this case. And we can then utilize this bone in many instances for grafting. You can see how excellent the healing has been. This is actually the grafted bone from the previous extraction, and at 3 months, this is healed up extremely well. We now have a wide base. You can see that this is going to be a wide diameter implant. We're quite a distance from the mandibular nerve. The patient was very concerned about possible damage to the nerve, and utilizing this concept that we can be certain that we maintain a safe distance from the mandibular nerve. Once the trephine core is removed, we can then go on to the final drill. And what this does is it has a dedicated drill with a laser mark, as you saw here, to place the head of the fixture just below the crest of the bone. Once this is done on slow RPM, we can then utilize the final bone tap instrument. This actually scores the threads of the implant into the surrounding dense cortical bone. This is done at 20 to 30 RPM at 30 to 40 Newton centimeters with copious irrigation, as you see here. And what this allows us to do is to get a very intimate relationship of the future implant. You can see the scored bleeding thread design in the cortical bone that has been actually facilitated utilizing the bone tap. So we can make sure that we're going to get very, very nice adaptation. In this case, a 7.5 by 8.5 millimeter length implant. These implants go up to as much as 8 millimeters in diameter, so they're very unique. And certainly they are a good addition to the armamentarium for the posterior replacement of missing molars. Here's the implant, as you see here, micro-textured surface with a rounded shoulder. It has a built-in platform switch, a very nice concept for the management and maintenance of crestal bone. The implant is now inserted utilizing the previous bone tap, and this can go in precisely and nicely adapted to the surrounding bony walls. This is at 30 Newton centimeters. We now have to tap it utilizing a hand ratchet down to 45 Newton centimeters of initial insertion torque. The internal connection of this implant should be placed right at the crestal bone level. And as I mentioned before, this has a natural platform switch or sloping shoulder design, which seems to be ideal these days for the maintenance of the crestal bone. Once again, one of the issues with placing a very wide diameter implant is that you're normally going to be engaging the cortical walls on the lingual and buccal aspects. So it's often very important that we go ahead and use the bone tap drills before insertion of the implant. Here the implant is placed. You can see a close-up of its intimate connection and adaptation to the surrounding bony walls. Remember, 3 months earlier, the tooth was extracted. In many cases, we can do this simultaneously. And remember as well, utilizing the bone that was harvested from the trephine drill, you can see this is identical basically to the size and diameter of the implant that was placed, 7.5 millimeters in diameter by 8.5 millimeters in length of autogenous corticocancellous bone that can then be ground up or placed in a bone mill and utilized for further bone augmentation on the buccal aspect. Because of the good initial stability, we have decided to do a one-stage procedure, and we're going to place a 3 millimeter high healing abutment with a flared collar. And this, as you can see very nicely, you can see the platform switch, the body of the implant, and the diameter and size of the healing abutment. The autogenous bone, cortical cancellous, that was harvested from the trephine is then placed and adapted around the neck of the healing abutment and the neck of the implant over the shoulder in an attempt to actually have bone above the occlusal table of the implant or above the fixture level, and also to further enhance the buccal contour and to preserve that buccal bone. This autogenous bone can be mixed with PRF or PRGF, or bioactive, blood-borne bioactive modifiers. And you can see we've maintained a zone of 2 to 3 millimeters of keratinized attached gingiva that we can then utilize to place and secure the soft tissue in a one-stage protocol. This allows us now to have bone on the facial aspect over the shoulder of the implant, but also to have keratinized dense tissue over the facial aspect of the future restoration, which is often extremely important for long-term maintenance, and as we've seen from the literature, extremely important to maintain and preserve the crestal bone levels. So as we've seen, simple suturing here, and as I've tried to mention, this is certainly something these days that can be done in a one-stage procedure, but I feel much more confident when I can come back and get these cases done in 2 stages. If you'd like to try doing this at one stage, a first day of extraction, obviously removing the septal bone between the roots of the extracted molar is a little bit more technique challenging, but very much doable and with a high success rate. I think for those first starting out with this system, a delayed approach like this one will let you feel more comfortable with the drills, with the trephine, and with the utilization of super wide, short diameter implants. What we tried to do is show you before the X-ray a new piece of the armamentarium, making sure to stay away from the mandibular nerve, utilizing wide body, super short implants, and in this case, utilizing the MegaGen implant system. Thank you very much for your attention, and I hope to come back at a later date and share with you the restorative phase of this same case. Look forward to seeing you again on Dental XP. I'm Dr. Maurice Salama.